Hello, class. This is Professor Cornell. This is tape 5 of Fluid and Electrolytes Part 2. So we were interrupted from this question. The answer to it is hematocrit is 56. That indicates the patient is hemoconcentrated or has hypovolemia. Also, that's probably the reason why their sodium is a little high. All of these others fit more with if they have too much water. So they'd be hemodiluted. Magnesium. Magnesium is also in the bone. It's in the cartilage. It's important for cell growth, cell metabolism. It's a membrane stabilizer. It's regulated in the kidneys, absorbed in the small intestine. And if the calcium and potassium is low, you can expect that the magnesium will be low too. They go together. So the causes are almost all related to problems with absorption in the GI tract, diarrhea, decreased malabsorption syndrome, laxative use, Crohn's disease, but also renal problems with the renal kidneys, use of diuretics and some other medications. So the low magnesium is going to cause increased membrane excitability. So you'll be more irritable, the muscles will be hyperactive, deep tendon reflexes, they're at risk for seizures, EKG changes, that's the muscle effect, levels of consciousness changes, mood swings, difficulty swallowing, that's part of the effect of the muscles, and then your GI symptoms. So the hypermagnesia would cause reduced membrane excitability. So again, you'll have GI symptoms from reduced peristalsis, drowsiness and lethargy, and decreased muscle strength. Low blood pressure, hypotension, and again, you'll have dysrhythmias. So these all, fit. They sound similar to other electrolyte imbalances. So the treatment is to, of course, you're going to monitor their cardiac rhythm. In either case, assess for changes in mental status and their neuromuscular status, assess the labs. You can give, so since swallowing can be affected, especially in low magnesium, you want to stay with them when you give them anything by mouth. Initiate seizure activity for low magnesium. You can, depending on the severity, oral supplements, or there's IV magnesium sulfate. I'm not talking too much again about IV medication because you're going to have that in depth your third semester for those of you that are in the RN program. Okay, so for hypermagnesia, the high magnesium, again, some similar things. They still need to be monitored, their cardiac rhythm, and assess their neurostatus, their mental status, neuromuscular strength. If their kidneys are functioning, you want to increase fluids. And you may give a diuretic to help with excretion. And if the respiratory muscles are affected, you may need to help do some supportive action there. Okay, here's some magnesium questions. Patient is admitted to the ER. The patient receives dialysis on Tuesdays and Thursdays of every week. The patient is extremely lethargic, and family members report the patient has been taking a lot of Maalox lately due to upset stomach. Which of the following lab values correlates with this finding? So what is this patient, what's going on here? She's lethargic. She's taking a lot of magnesium in that Maalox. You know she's on dialysis, which is a high-risk population for electrolyte imbalances. She's got an upset stomach too. So the answer is 3.6. The patient is high magnesium, is A. Here's another question. A patient is being discharged after being hospitalized with a magnesium of 0.7. After diet teaching with this patient, which statement by the patient warrants you to re-educate the patient? A, I love eating salads with kale and spinach. B, I'm shocked mackerel contains potassium. C, I can't believe I have to give up dark chocolate. And D, tonight I'm cooking fried potatoes with a side of peas. The correct answer is C. Dark chocolate actually does have a lot of magnesium. This patient has low magnesium, so you want to make sure they understand what foods contain magnesium. Which question is most important for the nurse to ask the client who has a serum potassium of 2.9? The answer for this one is, so it's slightly low, the potassium, if they're taking diuretics or laxatives, anything that would cause them to excrete potassium. Which of the following is a factor which influences serum calcium levels? Okay, so is it vitamin K, sodium, potassium, or parathyroid hormone? So remember, the parathyroid hormone is what regulates calcium. The answer is D, parathyroid. Magnesium functions to prevent calcium absorption? No, it's assist in cell metabolism. Which one of the following in the history, physical, and review of data would lead to a diagnosis of hypomagnesemia? So what depletes magnesium? The answer is C, excessive diarrhea and vomiting. What is the cause of hypophosphatemia? That's low serum phosphorus. The answer is D, malabsorption syndromes. Again, the GI absorption is affected by. Okay, these are lists of the more commonly used, or different types of diuretics, the more commonly used ones. And then that we often give oral electrolytes, supplements. Potassium chloride is frequently given when a patient's on one of the loop or thiazide diuretics. And we also give a lot of calcium and magnesium. You'll see, or you probably have already given it in your clinicals. And K-exolate, this is given if the potassium is high orally, and it encourages potassium excretion. Okay, let's talk about IVs. Why do we have IVs? To restore or maintain fluid and electrolyte balance, give medication, and give blood products. Sometimes we use it for TP and long-term nutritional balance. And it's a way to get medications in the bloodstream very quickly. Now, the CDC has recommended that facilities have a team, an infusion team of people who have been specially trained in IVs. They found that this reduces the complications drastically. So most hospitals do have IV teams, and I believe a lot of the nursing home and subacute units have an outsource IV teams to come in and start if they need an IV or to maintain it. Now, the types of infusion therapy that we use are IV solutions, which we're going to learn about this semester. Blood products you'll be studying in your third semester, as well as giving drug therapy. Other than you may do a piggyback or IV antibiotic infusions, this semester you won't be giving an IV push or bolus medications. This is the concept of tonicity. This is how we classify the different types of IV solutions. Tonicity is another word for osmolality. Remember when we talked about serum osmolality? This is the same idea. So if we give something that is highly concentrated, meaning that the ratio of liquid to particles is higher than our normal body fluids, because of the law of osmosis, this is going to pull fluids. If we're putting this into the extracellular fluid, the bloodstream, this is going to pull fluid from the inside of the cell. Vice versa, if we give hypotonic solutions, these are solutions that are very diluted, much more so than our normal body fluids, where the concentration of water to particles is very low, this is going to cause fluid to move into the cell. This is a basic concept that you need to understand. So these are different fluids, 9 different fluids. These are the ones that are in your book, in your Iggy book, and there are many, many more fluids than this, excuse me. But these are some basic ones, and they're categorized by their tonicity. Now, 0.9% sodium chloride is isotonic. This is the normal body fluid amount of tonicity. So any of these that are isotonic, that's the case. There's 3 here. 0.9 sodium chloride, D5W, which is dextrose, 5% dextrose in water, and the lactated ringers. These are all isotonic. So if you look at solutions where the sodium chloride is less than 9%, they will be hypotonic. The 0.45 sodium chloride is hypotonic. That's the only one listed here. However, there's a caveat. If the solution has dextrose in it, that raises the tonicity at least temporarily. So this D5W, 5% dextrose in water, because it has dextrose in it, that's going to make it an isotonic fluid. If it was just the water, it would be hypotonic. But once the body has metabolized the dextrose, these then become, the tonicity decreases. So if you look at this, 5% dextrose in water is isotonic, but I don't know why this thing is moving like this. 10% dextrose in water, because of the dextrose, it's hypertonic. And all of these with dextrose in them are hypertonic, at least temporarily, until the dextrose is metabolized in the body. Lactated ringers is isotonic. It has extra sodium and potassium and different electrolytes in it. And this is lactated ringers, but with dextrose added, so it's hypertonic again. I just want you to have an understanding of the concept of the categorizations of fluids. And if you can be familiar with these more commonly used ones, so that you know when you get into the unit what people are talking about. If they say, go get me some D5.5 or some D5W, you know what they're talking about. Or some normal saline is what they'll say. If you have a general idea of why these would be used, so if you're just replacing fluids, if the patient is hypovolemic or dehydrated, they'll most likely give an isotonic. But if their sodium is real low, they may choose to give a hypertonic, at least for a short period of time. Okay, so IV infusions. So we have continuous IV infusions where a patient is getting a solution to correct a fluid or electrolyte balance, and we have intermittent. These are like IV antibiotics that are hung for an hour, a short period of time, and then disconnected so that the patient isn't so confined with an infusion. You'll see these commonly used in the subacute units. The PRN angio caths are just like a short peripheral line that can be accessed if needed. So peripheral therapy, these are the short peripheral catheters. They're usually inserted in the dorsal surface of the hand and the forearm. They are only good for 72 to 96 hours, and then they have to be removed. We have some tools that help with insertion to find veins. The PRN adapter or heparin lock is what you'll commonly see in the hospital. Almost every patient, they insert these in case we need access. They're not well, they will be hooked to something if they need to be, but they're just, you'll see them, they look similar to this in the hospital. Short birth, they're, again, only for short term. If they're needing to have therapy for longer than 6 days, then they would choose a larger catheter and a larger vessel. So these are the different veins that they may use.